Yes. Is my screen visible to all? The question is diastolic dysfunction. What to do now? We all have encountered echo reports which say that there is type 1, type 2, type 3 diastolic dysfunction. But we do not know how to interpret this and how this diastolic dysfunction translates into clinical practice. Most of the times, we have seen clinicians just looking at the ejection fraction. Now, ejection fraction is just two words. There are another 100 words in the final echo report. We need to understand how do we understand, interpret, and help our patients with this. So let's come back to the basics. Systole means cardiac contraction. At that time, calcium ions are released into the cytosol through the N-type calcium channels. Diastole, that means relaxation. These calcium ions, which are released into the cytosol, are taken up again. So this way, during systole, calcium ions are poured, and during diastole, these calcium ions are taken up. So what is diastolic dysfunction? Basically, failure to take up the calcium ions into the cytosol leads to impaired relaxation. And this impaired relaxation is leading to ventricular stiffness, increased ventricular pressures, and this entity is called diastolic dysfunction. Let's try and understand what are the basic factors leading to diastolic dysfunction. Factors can be intrinsic, that is inside the heart, or extrinsic, that's outside the heart. So intrinsic is the elasticity of the ventricle, maybe passive elasticity or active elasticity. The wall thickness in patients of hypertension, diabetes, hypertrophic cardiomyopathy, the left ventricular wall thickens. Now, next we need to understand that what is the composition of the LV wall? Is it just pure muscle, or is there fibrosis or hemosiderin deposition, amyloid deposition, as seen in hemochromatosis or amyloidosis of the heart? There may be slow relaxation due to slow uptake of calcium ions, or if it is severely impaired, there might be incomplete relaxation. The extrinsic factors would be pericardial thickening, RV loading, coronary vasculature calcium, which impairs the relaxation, external tumor, pleural pressures, etc. So now, what is diastolic dysfunction and why is it so important? We need to understand that diastolic heart failure occurs in 40 to 50% individuals. In other half patients is systolic heart failure. So the ejection fraction, low ejection fraction accounts for only half of the cases of heart failure. Remaining half cases of heart failure are due to diastolic dysfunction. Unfortunately, mortality and morbidity is extremely high with both systolic as well as diastolic dysfunction. So, we need to understand how to identify it, prevent it, and treat it effectively. Most important is the clinical scenario, signs and symptoms of heart failure. If a patient is complaining of exertional breathlessness or exertional fatigue, I would keep heart failure at the back of my mind. Of course, ejection fraction more than 50%, documented diastolic dysfunction on the echo, and elevated N-terminal pro-BNP more than 3 to 5 times the upper limit of normal. This is diastolic heart failure. What are the causes of diastolic heart failure? All of us see n number of patients in our OPD having hypertension, diabetes, obesity, obstructive sleep apnea, etc. So these are the major causes of diastolic heart failure. Of course, to complete the list, cardiomyopathies, constrictive pericarditis is very important. Most often, coronary artery disease causes systolic heart failure, but yes, in preserved ejection fraction, it can also cause diastolic heart failure. So now let us understand how your echo report would look like and what do you do as a clinician in your OPD if you encounter this echo report which has diastolic dysfunction. So first, a short note on what we do while doing an echocardiography. So the diagram A has an inverted image of the heart in which the ventricles are on top and the atria are below. My pointer points to the mitral valve. We keep the cursor here and do a pulse waved Doppler velocity. And this pulse wave would give an image like this. You see that's E and you see this A. What does E and A mean? It's not just a vowel, it's much more than that. E means most of the heart filling, that is 80% of the heart filling, occurs in the first rapid filling phase. What is that? That is when the diastole of the ventricle starts, the mitral valves will open up and spontaneously 80% of the blood flows from the atria into the ventricle. That is spontaneous. The remaining 20% of the blood comes into the ventricle because of the atrial contraction, that is in the end. So E means early rapid filling phase and A means atrial contraction. 80% of the volume, so this is 80% of the volume of blood flow during early diastole happens due to the early rapid filling phase. So of course, if maximum blood flow occurs during the early rapid filling phase, the height of the E wave is supposed to be larger. Now, only 20% occurs due to the atrial contraction. So the height of the A wave is very small. So we usually take the E divided by A velocity for calculating the diastolic function. Now this ratio in a normal individual would be somewhere between 1.0 to 2.0 depending upon how much blood enters, but definitely more than 1. Now let's see. So this is the diagram which shows 80% of the blood filling in the early diastolic phase and another 20% filling in the atrial contraction phase. Now the speed with which the blood flows from the atria to the ventricle is calculated by something called as the deceleration time. So you see this slope. Cardiology is all about mathematics and slopes and everything. With that, we can calculate the speed of blood flow, the pressures in different chambers of the heart, and everything without even putting inside a needle or a catheter. This is extremely important because you would get pictures showing this E and A. So let's see how we calculate the deceleration time. This is the deceleration time. This black line, dotted line is the deceleration time. We just put the cursor on this and draw a line and it gives us the slope. Next, we also calculating diastolic dysfunction. One, I said that we calculate the flow of blood, the velocity of blood at the point of mitral valve. Next is we are calculating the velocity of tissue movement at the mitral annulus. That's called tissue Doppler imaging. So we keep the cursor on the mitral annulus at the septum and we get E prime and A prime. What is E prime? E prime means that is the velocity with which this mitral annulus moves during the first rapid filling phase. Of course, if maximum blood is flowing during the first early rapid filling phase, the movement will be maximum during the early rapid filling phase. Hence, this is the tissue movement of the early rapid filling phase. Next, you have the A prime, that is the last atrial filling phase, is of course supposed to be small. Now, this chart is extremely important. If you just remember this one chart of the entire talk, I'm sure you would be able to remember how to manage patients of diastolic dysfunction in your OPD. Don't worry, I'm going to share this presentation. It is getting recorded. So grade 0 normal, that is E is greater than A. Grade 1, that is as the diastolic stiffness increases, as the ventricular stiffness increases, the ventricle will allow less amount of blood to flow into it during the early rapid filling phase. Hence, the atria will have to work harder to push more blood. So the E is smaller in height than the A. It means the early rapid filling phase, the blood flow is lesser, the ventricle is stiffer. And A means the atria has to work harder than usual to pump the blood into the ventricle. Next comes the grade 2, pseudonormal. What is pseudonormal? In pseudonormal, the pressure increases so much inside the atria, it goes higher than the ventricle, so that now the amount of blood flowing spontaneously from the atria to the ventricle increases. But that increases with increased pressure. So the E wave again becomes larger. And A is of course smaller in grade 2.
Mute my microphone when joining a meeting.
In grade 3, the pressure inside the atria increases manyfold. As a result, what happens is that the E becomes more than 2 times the height of the A wave. As a result of that, the E by A ratio is definitely more than 2. Similarly, in tissue Doppler, we see normally the E prime is like this. In grade 1, grade 2, and grade 3 diastolic dysfunction, the E prime velocity reduces and we get lesser movement of the mitral annulus. Other things we can do is pulmonary vein Doppler, hepatic vein Doppler, superior vena cava Doppler, etc. This is a diagram of the pulmonary vein Doppler. I'm not going to go into the details. So most important is we measure the E velocity, E prime, E by A ratio, and E by E prime ratio and tell you about the diastolic dysfunction. Another important criteria, as we know that for sugar measurement, HbA1c tells a average sugar level over 3 to 4 months. Similarly, the volume of the left atrium tells us an average pressure of the left atrium over the past 4 to 6 months. So, left atrial volume is extremely important criteria to detect long-standing diastolic dysfunction. Of course, left ventricular hypertrophy in patients of hypertensive heart disease, hypertrophic cardiomyopathy, and so on. Associated valvular heart disease like mitral stenosis, regurgitation, aortic stenosis, aortic regurgitation, etc. Regional wall motion abnormality, and most importantly, your clinical judgment, that is, patient's clinical complaints, pulse, BP, respiratory rate, SpO2, is the most important in detection of diastolic dysfunction. So, my friends, we're coming towards the end of the talk. This is the take home message. If on an echo report you see grade 1 diastolic dysfunction, usually the patient will be clinically asymptomatic, but it means that you need to intervene now. This is the time when you need to prevent exercise induced tachycardia, because if there is tachycardia or atrial fibrillation with exercise, the atrial kick will be lost. And if the atrial kick is lost, the pressures in the atria will increase. And this will lead to decompensation of these patients. So, grade 1 diastolic dysfunction, asymptomatic patient, treat the patient with beta blockers and start antihypertensives, antidiabetics, obstructive sleep apnea syndrome, and ischemia treatment. The idea is to prevent progression of diastolic dysfunction and prevent occurrence of diastolic heart failure. If we see grade 2 diastolic dysfunction on the echo report, the pressures in the atria have already increased. So now you need to reduce the preload. Plus, there would be some neurohormonal changes happening. What do you do for that? Your ACE inhibitors and ARBs are the best classes of drug to reduce preload, afterload, and for neurohormonal regulation. So that time you give ACE inhibitor and ARB. If you see someone having grade 3 or grade 4 diastolic dysfunction, it means the pressures in the atria have increased many folds. First of all, you will need to reduce those pressures. That is possible only by giving initial diuretics. With initial diuretics, you reduce those pressures. Then you need to also do neurohormonal regulation, that is through ACE inhibitors or ARBs. In grade 3, grade 4 diastolic dysfunction, do not give beta blockers. So this is the clinical take-home point of understanding what is diastolic dysfunction and how do we handle patients with diastolic dysfunction on an OPD basis. So my friends, it's extremely important to translate knowledge into clinical practice. I'm sure all of us attend lots of webinars, but unless we use this to help our patients, it's not going to be of any benefit.